Welcome back. This is fantastic. Welcome back to another episode of Elite Medical School. We're so excited to join you folks today for a wholesome discussion on sexually transmitted illness and infection. Joining us today is our resident standardized patient who really seems to suffer from just about every illness that we discuss, and that is Dr. C. How are you, sir?
I'm doing very well. How are you doing?
I'm fine, thank you.
And yeah, I do have every ailment known, but I don't have the subject of today's podcast. That's the one thing that I don't need to worry about at all.
Well, is that because you're an incel?
That's correct.
That is correct.
That's okay, man. I'm MGTOW.
Yeah, that's I classify myself as MGTOW.
Yeah.
There have been chlamydia outbreaks linked to gooning caves. Like there's sort of MGTOW communities that will congregate in gooning caves.
Yeah.
And
yeah, I'm abstinent, but I still managed to get chlamydia from. We weren't doing anything gay though.
Yeah.
We weren't doing anything gay. I'm telling you, man. I know it sounds gay. I know it sounds really gay, but it's not.
Anyway, we're not here to judge. Not here to judge at all. Either way. But admittedly, that's one of the risk factors that we'll be talking about for STIs. So this should be a high yield discussion. A lot of stigma associated with STDs used interchangeably. And that's why bringing a little bit of levity to this situation, I think, is helpful. I think this is part of the cure, right? So we can just sort of jump right in. We can just start plowing away, no pun intended.
All right, let's get into it. Let's talk a little bit about epidemiology. STIs, high incidence rates worldwide, especially some of our more common presentations. So we have chlamydia, which is probably the most common one you'll encounter in everyday clinical practice. Gonorrhea would be the second most common. And we'll also be watching out for things like HPV, genital herpes, some less common infections. We want to think about syphilis, HIV, hepatitis B, and trichomoniasis.
Crabs,
yep. Pinworms.
That's more of an animal than like an infection.
Mm-hmm. Yeah, well, yeah, it's a mite. But if you're rubbing the nasty parts together, I suppose you could transmit it. So yeah, certainly, mite infections are something that we might think of.
Okay.
Yeah, so I think that's a good outline of some of the more common ones. So crabs, also known as pubic lice, but in fact, scabies is probably more commonly transmitted. Scabies is not uncommon, especially among low SES, and they can colonize the pubes. So there you go. So yeah, so speaking of sort of risk factors, so I had just mentioned low SES being a non-heterosexual, that is MSM, FSM, any sexual minority group, sexually active youth who are under the age of 25, especially for chlamydia and gonorrhea. So a very high risk group, and in fact, it's one of there is evidence to offer for any sexually active use under the age of 25, at least in our local guidelines, annual screening for STI, which is sort of interesting. It's straightforward, formally, and we'll get into it There was an aggressive sort of violating swab. Now it's just a pee test. What else? People that don't use barrier contraception, that's going to be high risk. IV drug use, and then of course sex workers. So those are some important risk factors.
Yeah.
Also, the among the MGTOW community, there's a higher prevalence of chlamydia. So be considerate of that population too.
And some easy answers that you can throw into an exam are very obvious things like sexual contact with a person with a known STI or having a previous STI. Those are just easy points you can throw in. Some other risk factors might be if you're a Chad or Stacy, my ex-girlfriend, maybe even a little bit of swinging could be a bit of a risk factor if you're
Also
not.
being uncircumcised as well.
Yes, yeah, being uncircumcised.
And so in terms of patient presentation, we have a gentleman like Dr. C. He comes to your clinic. He's disheveled. He has poor grooming. He's pansexual. He's a sex worker. He has a history of IV drug use. Yeah, he's definitely, yeah. He's had multiple partners within the gooning community in the past year. So what symptoms might he present with? Well, this time he comes in as usual, complaining about genital rash. He says, hey, Dr. T, I've got another rash on my unit. Do you mind having a look? And indeed, there's sort of this vesicular rash, which makes us think of herpes. Now, this is not Dr. C's first brush with herpes. In fact, it's an illness he's come to know quite well. However, this time, it's associated with urethral discharge. So another key symptom. And indeed, he has some testicular pain as well as inguinal lymphadenopathy, or swollen lymph nodes in the inguinal chain. Furthermore, Dr. C complains of a sore throat as well as some oral ulcers and anal symptoms. So these are, remember, with sort of progressive sexual practices, symptoms can present at different orifices, and a broad history is going to be important, especially for folks that are in sexual minority groups. So this is not the time to be shy, and it can be serious. For example, condylomas in the anal region is a serious risk factor for anal cancer, and I've seen that. So now is not the time to be shy. Any other sort of important signs or history to elicit for a gentleman like Dr. C coming into your office?
Right. So one thing that we can discuss is, what is Dr. C's understanding of STIs? Does he know what they are, how they're spread, and what high-risk behaviors are? Similarly, have they talked with their partner or partners or other gooners about STIs and whether their partners might have contracted something in the past? When did they get tested last? What kind of contraception are they using? We really want to focus on, barrier protection. Have they had previous STIs, and have they had previous testing? Dr. C might want to ask him when his last pap test was.
Anal pap is used in the MSM community. Anyway, yeah.
Yeah.
Excellent.
Maybe asking more about some systemic symptoms like fever or lymphadenopathy, things like arthralgia as well. We want to keep our differential broad. Not everybody that's coming in is just going to have chlamydia and gonorrhea. If there's a lot of high-risk behavior, we want to assess for some of the more serious things as well.
Yeah. So that and it's interesting, like things that you wouldn't even necessarily intuitively